Okay, thank you. Thank you. Nice to meet you, and thank you for having me. And I'm Eonjung Angeline Kim. I'm a new heading neurologist at Pacific Neuroscience. So today I chose this topic because headache is one of the most common medical complaints in any settings of like medical fields. So I think this would be like a good introduction of how to like approach a headache patient the first place and really like recognize what are the red flags and in that case what should we do to prevent any like dangerous outcomes or non-reversible outcomes, and then trying to have like a accurately diagnose the patient. So these are the objectives that was introduced early, and then we're going to go over them. So the most fundamental classifications is primary headaches versus secondary headaches. Primary headaches are basically those headache disorders that are not caused by any underlying medical condition or structural abnormalities. And secondary headaches are the headaches that are caused by some underlying medical conditions or structural abnormalities. And um, in that case, we need to figure out what are the underlying medical condition or structural abnormalities if to potentially treat the headaches. Okay. Okay. The differential diagnosis of secondary headaches is fast. ICHD, the international classification headache disorders, kind of like provided this list of 8 big types of secondary headaches. And I can introduce them here for like a general overview. So first is like trauma or injury to a head and neck, such as post-traumatic headaches is one, and cranial or cervical vascular disorders like ischemic strokes, subarachnoid hemorrhage, subdural hemorrhage, vascular malformations, arteritis, dissections, or CVST, cerebral venous thrombosis, or RCVS, like reversible cerebral vasoconstriction syndrome. There are non-vascular but intracranial disorders like IIH, idiopathic intracranial hypertension, or cancer, Curie malformation type 1, or any type of inflammatory disease inside of the brain. Or substance use withdrawal is one category, like medication overuse or withdrawal from like other medications. Fifth one is infections in the intracranial or just systematic body infection can lead to headaches. Six is homeostasis disorder like hypoxia, hypercapnia, sometimes related to dialysis, and arterial hypertension or hypothyroidism, like those endocrine disorders as well. Seven is a facial cervical structure disorders like any cervicogenic headaches or TMD, like temporomandibular disease. And eight is a psychiatric disorders like somatization disorder, psychotic disorder can present with headaches as well. So how do we approach a headache patients? And nothing complex or nothing new, but history is definitely like one of the most significant um, evaluations when you approach a headache patient. And all primary headache disorders are basically diagnosed largely by history. And then all this is also how we recognize the red flag. And comprehensive neurological exam will be helpful to rule out any like focal neurological deficits. And once you recognize some red flags, then additional workup can be uh, are indicated depending on what types. And by these findings, we can eventually diagnose the headache and then lead to the appropriate treatment. So what does the detailed history mean? And so headache specialists usually spend at least 30 to 40 minutes taking a full history during the first outpatient visits. And thorough history helps diagnose different types of primary headaches and also recognize some red flags in the history. And it's always good to start with an open-ended questions like tell me about your headaches. And then the American Migraine Communication Study also show that open-ended questions tend to yield more or most information during the interview, especially regarding the impairment. So those are very important. And the list of the components of detailed histories are listed here. They're not comprehensive, but important, like onset, like when did it start? Is it a new headache? It's been around for 10 or 20 years. Quality, what type of pain is it? Is it stabbing, pulsating, sharp? Those will be all helpful. Duration will be important when you categorize the headaches into different types of the headache, primary headache disorder. Duration, it's important to recognize this first time, like for the onset to the like completely when it's headache free, not just only the severe time of the headaches. Frequency, like how often is it happening? So it'll be important if it's more like chronic patient, it'll be important for them to keep a headache diary. Severity, like it'll be good to give them a reference point, like 0 is no headache, like 10 out of 10 is the worst pain they can ever imagine. Severity is for that one. And then warning signs, like for migraine, there could be an aura or there be if those is transient, like warning signs, and they could be helpful for figuring the auras or not. Triggering, provoking factors are also important, and positionality, such as does your headache get worse with the lying down, or does headache get worse when you're standing up? Because they can tell the signs of any like intracranial pressure changes. Um, and autonomic symptoms like watery eyes, watery nose, swelling of an eyelid, or bloodshot eyes, and or sometimes just a flushing or ear fullness. Those are all like autonomic symptoms, and associated symptoms in patients' words, like any overlapping symptoms or any concurrent symptoms with the headaches will be helpful to figure out what's going on. And progression of symptoms over time and getting worse over time is always the worst, always a kind of red flag. And what does the comprehensive physical exam involve? Like vital signs, general comprehensive neurological exam. If possible, fundoscopic exam would be helpful, especially to rule out any papilledema, the pressure against the optic nerves from behind the optic nerves, so intracranial pressure. And then sometimes palpation of the cranial peripheral nerves can provide some hints, like any neuralgia, for example, like occipital neuralgia. And this picture shows like the occipital nerves are on the back. On the side is like a auriculotemporal, and there are two big nerves, like supraorbital and supratrochlear. If this could be helpful, especially for primary headache disorder, because if there's any tenderness, we can actually block them with a nerve block with a lidocaine or bupivacaine. So I want to go over this mnemonic of like Snoop 10 criteria. And we can just think like a Snoop for red flags for secondary headaches. But it's 10 because there are 10 P items. So we're going to go over that. And so this kind of provides a framework to when taking history or an exam that should lead to further investigation. So let's go from S of Snoop. S is systemic symptoms, including like fever, because it should bring a red flag to think of infection, carcinoid, or pheochromocytoma. N is neoplasm in history, like is it brain cancer or metastases are in question? Or another N, or is there any neurological deficits or dysfunction that includes decreased consciousness? Then we can think about like vascular disorders, brain abscess, or infections. O, onset of headache, is it really sudden or abrupt? That will lead to like that kind of can include the thunderclap headaches, like a sudden, really abrupt, severe headaches. Then that can mean the subarachnoid hemorrhage from aneurysm rupture or any other like vascular disorders as well. Another O, on older age, usually above 50s. If there's any new headaches after age of 50, we have to think about those conditions that's related to older age, such as giant cell arteritis or vascular disorder. So imagings are usually warranted. So these are the 10 P symptoms or signs. So first, pattern change. If the headache was always on the right side and then pressure-like, but suddenly it's left side, sharp, pulsating, that could be a pattern change. And then we have to think about it, rule out and neoplasm, any vascular or any intracranial disorder. Positional headaches, as I mentioned briefly earlier, if there's any certain change with the positions all the time, then we think about any pressure change in the head, like intracranial hypertension or hypotension. And I will go in more details later in the talk. Another P is precipitated by sneezing, coughing, exercise. Then we have to rule out any posterior fossa malformations, Chiari malformation, and papilledema. That's more exam sign, and that means there is some pressure behind the optic nerve. That means intracranial, anything that can increase the intracranial pressures, like neoplasm or just intracranial hypertension or other disorders that can have a mass effect. Another P, progressive and atypical. If it's progressively getting worse, we have to rule out cancer. And another P, pregnancy or perineum. Those are the high risk population that if they develop new headache or change in headache in those period, then we have to rule out other causes. They're highly coagulable state. So any like CVSD, like cerebral venous sinus thrombosis, or if they get like epidural history, then we think about the post-dural puncture or any vascular disease, any endocrine like um, the hormonal dysfunction and other conditions as well. Under P is painful eye with autonomic features. If you think about the history, you can consider like cluster headaches, like those are unilateral painful eye with ipsilateral autonomic features. But also it could be secondary headaches, like posterior fossa or pituitary reason abnormalities or mass or cavernous sinus. And Toulouse-Saint syndrome is included here is more rare disorder that is inflammatory rare disorder that causes unilateral headache, orbital pain, and also weakness of the eye muscles of that eye. So you can always also try to rule out the ophthalmic causes. Another P, post-traumatic onset. So if there's any changes from trauma like subdural hematoma, vascular damage. And next P is pathology of immune system, like immunocompromised state like HIV. Then we should think about if there's a chance of opportunistic infections intracranially. And next P is painkiller overuse or new drugs. Those are the medication overuse headaches or drug impatibility and such. Okay, so those are a lot, but today I want to just focus on more, a few of them, and then talk to you more about what those are, and the four headache symptoms that should not be ignored, and the associated headaches with those symptoms. So we're going to go over the thunderclap headaches, any headaches with systemic symptoms, or vision loss, or increased or decreased intracranial pressure signs. First, let's talk about the thunderclap headache. Like thunderclap headache, as you all already know, is a very severe headache of abrupt onset that reaches its maximum intensity within 1 minute or less of onset, or sometimes the very extreme severity is alone, like a clap of thunder, can be sufficient to be considered. And these are actually a medical emergency that requires immediate evaluation, and they can come in headache by itself or with additional symptoms like fever, altered mental status, seizures, or motor or sensory deficits like neurological deficits or cranial nerve deficits and or meninges misstyles. And most frequent causes of thunderclap headaches are subarachnoid hemorrhage and RCBS. And let's talk about the subarachnoid hemorrhage first. It is one of the most common causes of persistent, intense thunderclap headaches, and 80% results from ruptured saccular aneurysm. And saccular aneurysm basically just an aneurysm that looks like a stack like a pouch. And mortality is pretty high, 40 to 50%. and 10 to 20% of patients actually die before arriving to the hospital, and 50% of survivors left disabled. So it's pretty serious disease. And 50 interesting thing or something that we can do something about it is that the 50% report sudden severe headaches within 4 weeks prior to those rupture. So if you recognize that, we can and then do appropriate imaging studying and recognize that we can actually prevent them to lead to subarachnoid hemorrhage. And I will say that any thunderclap headaches will need a neuroimaging, and non-contrast CT will be the first. And it'll be 99% sensitive if it's taken under within 6 hours, and then the sensitivity kind of goes down with time. And if the CT is negative, but there's a high suspicion lumbar puncture should be done, and it will show the xanthochromia. And it's the best to be collected between 12 hours to 2 weeks since the first onset. And when you find this subarachnoid hemorrhage, it is a neurointerventional emergency as well because they need to identify non-ruptured aneurysms and treat it. And these are the CT scan of the subarachnoid hemorrhage. You can see this um, hyperdensity in these cisterns. And then this is a xanthochromic CSF with lumbar puncture, that's a yellowy fluid. And moving on, the reversible cerebral vasoconstrictor syndrome, I'll say RCVS, it's another common cause of the thunderclap headaches. And then it comes from the reversible segmental narrowing of the cerebral arteries. The characteristic that is different from the subarachnoid hemorrhage is it's recurrent and over a few days or weeks, and they can stimulate aneurysm and subarachnoid hemorrhage eventually. There could be as triggers like sexual activity, any physical exertion, Valsalva, or heat or cold exposures to postpartum state, recreational drugs, and sympathomimic drugs like clonidine, midodrine, methyldopa, phenylephrine can actually trigger this RCVS. And besides a thunderclap headache, they can be associated with seizures or fluctuating focal neurological deficits. And initial MRIs actually can be normal in 30 to 70%. But if it's recurrent thunderclap headache, the RCBS, differential diagnosis should not be abandoned because the later MRI can show the RCBS. The imaging sign, you will see the sausage on a string appearance of circle of Willis, and they resolve spontaneous over a few weeks. And there's no proven therapy for RCBS, but they should be getting the supportive care to manage blood pressure and headaches and other complications like seizures. And calcium channel blockers, imodipine, verapamil can help reduce headaches. And these are the imaging examples. I'm sure you guys can see it well, but the sausage of string is basically the segmental narrowing of those cerebral arteries. Like, you can see it over there compared to normal, and then over here, maybe you can see it a little bit better, like a sausage link. Okay, but these two are not the only causes of the thunderclap headache. There are others listed here, like CBSD, like cervical artery dissection, infection, plus like spontaneous intracranial hypotension, like third ventricle cholecyst or pituitary apoplexy. So evaluation thunderclap headache, you should start with the CT head and additional vessel imagings as needed. Okay, the second symptom will be the systemic symptom. So if you see like headache and fever and then some like altered mental status, Glasgow Coma scale under 14, and nausea, like you should consider meningitis. And they can have focal neurological deficits and seizures. And that the common bacterial etiologies are strep pneumoniae, Neisseria, Listeria, and viral etiologies like enteroviruses are most common. Arbovirus, polio, echo, Coxsackie virus, HSV, VZV, adenovirus, mumps, HCV are listed here. And it's an emergency as well. They need an urgent lumbar puncture and empiric antibiotics and antivirals until CSF results. And it's been always questioned that when we need to do the head imaging before lumbar puncture. Not everyone needs CT head before lumbar puncture, but there are certain cases that you would get CT before lumbar puncture. And the reason is to exclude increased intracranial pressure so it doesn't lead to the cerebral herniation because that'll be best in devastated. And those conditions or those indications include the immunocompromised state or history of a CNS lesions or disease like mass lesions or stroke in the past, or new onset seizures within 1 week of presentation because we don't know what's going on in the brain, and papilledema that shows the signs of increased intracranial pressure, any abnormal level of consciousness. That's also because like they wouldn't be able to give like an accurate history, and then focal neurological deficits as well. Okay, so moving on, the vision loss. Vision loss associated with headaches should be taken seriously because those vision loss might not be reversible. So first condition is I'm going to talk about is giant cell arteritis. These are the one of the most common systemic vasculitis that involving large and medium arteries. And of all the arteritis and collagen vascular disease, giant cell arteritis is the most most associated with headaches because of the inflammations of cranial arteries and especially the external carotid artery branches. It almost never occurs in younger patients below 50, and the peak is in the 70s. And major risk is blindness. It can be like irreversible too because of the anterior ischemic optic neuropathy. And people with GCA also at a high risk of cerebral ischemic events and dementia. So suspect GCA whenever you see one of these symptoms plus elevated ESR and CRP. So what I would usually do is even though they don't have the classic GCA patterns, but they're presenting with visual symptoms and older of age 50 and and then the symptoms that are close to one of these, that I will get the ESR and CRP just to make sure that we are not missing it. And those following symptoms include this new headache or change in pre-existing headache or abrupt onset of visual disturbances, usually monocular, and jaw claudication, and unexplained fever or signs of any other vascular abnormalities like limb claudication, vascular buoy, tenderness to temporal artery. The confirming diagnosis is through temporal artery biopsy, but you cannot wait for temporal artery biopsy to start the treatment to prevent the vision loss. And the treatment is the high-dose glucocorticoids, usually with prednisone 40 to 60 milligrams per day. And then you can lead to the temporal artery biopsy. And this picture showing the histopathology of the GCA, left is normal, right is abnormal. And this one showing this transmural monocular cell infiltrations and intraelastic lamina breakdown and intimal hyperplasia. And then you can start with the prednisone high daily and then see how the symptoms go, how the visions go, and then eventually slowly taper off. Okay. The second condition that I'm going to talk about the headaches with vision loss is idiopathic intracranial hypertension. I'll say IIH. So the IIH means that there is an intracranial hypertension, but with normal CSF and no other structural cause of intracranial hypertension. So they sometimes refer this then refer this as benign intracranial hypertension as well. And the childbearing age and overweight females are high-risk patients. And what are the like common presentations? Headaches are the most common, and they will have a transient obscurations, the transient vision loss, like blackout vision, few seconds to few minutes. It can be triggered by changes in postures or valsalva, or it can happen at random times as well. And they hear intracranial noises, usually pulsatile tinnitus rather than the like high pitch constant like buzzing. So people say sometimes it feels like a whooshing noise that pulsate. And other symptoms include photopsia, which is a flashing light, back pain, interestingly, retrobulbar pain, diplopia, sustained vision loss, and neck pain are the examples. And the initial study of evaluation includes MRI brain, but not always MRV, but MRV can be obtained if there's any risk factors or signs of cerebral venous sinus thrombosis, like people on OCP, hormonal replacement therapy, to rule out other causes. And ophthalmologic examination will be important to rule out papilledema. And officially the confirming diagnosis is the lumbar puncture with the opening pressure over 250 millimeter H2O. And LP, not every LP is lumbar puncture is important, but it has to be done in a right way to avoid any false results. It has to be in lateral decubitus position with legs extended, which is opposite. Usually the legs are like flexed. And other positions, prone or sitting, anxiety or pain can falsely elevate the measuring opening pressure. So it's important how you get the opening pressure as well. So these are just showing the normal optic disc or what you would see for papilledema. So blurring of the optic disc margins, and then you can sometimes see those vessels are not disconnected almost. And how do we so once you're diagnosed with IIH, what is the treatment goal is to prevent the permanent vision loss and headache, and then control the headaches, so symptom-wise. And then we need to send the patients like serial ophthalmology examinations to prevent those vision loss. Weight loss will be helpful, and then the line of medications like first acetazolamide to lower the CSF pressure, but topiramate and furosemide can be used as second line. If there's any rapid progress vision loss at the first presentation, then we will need all of them, like furosemide, serial lumbar puncture, and also if there's a vision loss that is already happening, the consultation for surgical intervention may be needed for optic nerve sheath fenestration and CSF shunting process. Okay, so the next one is increased or decreased ICP signs, intracranial pressure signs. Increased intracranial pressure sign that kind of goes along with IIH that we just talked about. The headaches that are worse in the morning or when lying down, or lying down for a long period of time, but it improves when sitting up or standing up. It worsens by Valsalva, like coughing, straining, and then they hear this pulsatile tinnitus or have a TVO and have papilledema on the exam. The causes other than the IAH, there could be other causes like metabolic, toxic, hormonal causes such as acute hepatic failure, renal failure, hypercapnia, hypercarbia, acute hypertension crisis, or CVSD. And other ones include like thyroid hormone replacement, retinoic acid, or tetracycline vitamin A toxicity, and straight withdrawal. They can also have this increased ICP signs. Chromosomal causes, Turner syndrome and Down syndrome are associated to have this increased ICP. And then hydrocephalus, for whatever reason, also have this increased ICP signs. So since we talked about the increased ICP signs earlier with IIH as well, I'm going to talk more about the decreased intracranial pressure signs. They have these orthostatic headaches the headaches that worsen when standing up and sitting up, but improve or even disappear when lying down. So that's quite opposite of the increased intracranial pressure signs. They may have neck stiffness, and also they were LP, the lumbar puncture would show the low CSF sign, like less than 60, and or the evidence of CSF leak on imaging. And it could be procedure or trauma related that led to the CSF leak, like for example, like a post-dural puncture headaches. So even though it says the CSF is less than 60, we almost never send these patients with low intracranial pressure signs to lumbar puncture because by taking out those fluid of a patient who might have already low CSF pressure, it can worsen the headache. So we usually try to diagnose with this imaging. And so what are the imaging signs when you get in? The brain sagging, diffuse pachymeningeal enhancement, subdural hematoma, engorgement of dural venous sinuses, pituitary enlargement, spine imaging showing this epidural collection or collapse of dural sacs, engorgement of epidural venous plexus. You can see one, you can see multiple of them. So I included some pictures of it. So the A is a post-contrast T2 imaging on the astral view. First, you will see this diffuse pachymeningeal enhancement and pituitary enlargement over here. And then those are the distended venous signs. And this one is also the axial T2 imaging. And you can see some lateral compression of the midbrain with the increased anteroposterior diameter. The C, this one, you will see also again this is more severe lateral compression of midbrain, and then the ophthalmic veins are distended. Continuing, this is showing kind of brain sag and narrowing the mammillopontine space. And then B, spine imaging with the post-contrast T1, enhancement of the epidural venous plexus, and also dural enhancement. And then you can see those are the epidural venous plexus engorgement. And then this one C showing the scallop thecal sac and distended epidural veins. So this one's saying that so the conditions that can lead to this decreased ICP signs, one is spontaneous intracranial hypotension. It's spontaneous because it just have this dural tear or meningeal diverticula or CSF venous fistula, like spontaneously, not caused by any procedures or trauma. And you will see all these symptoms that I mentioned: orthostatic headaches, nausea, neck pain, tinnitus, changes in hearing, photophobia. And then diagnosis with imaging will be the next step. And so if you see any low intracranial pressure sign, you should order brain of the MRI of brain and neuroexit with contrast, so you can see this enhancements of the dura. And you have to also exclude POTS, posterior orthostatic tachycardia syndrome. Also screen for connective tissue order because Ehlers-Danlos connective disorder can have this SIH. The treatment, conservative if it's not severe, bed rest or oral caffeine, 200 to 300 milligram daily would be sometimes can do, but if not, you will need to use this epidural blood patch. But sometimes you need more than 2 rounds of the treatment to completely like help with the symptoms. Okay, so these are again some big 8 big categories of secondary headaches, and today we just talked about just the 4 big symptoms. So the take-home points that I want you to get from this lecture is that accurate headache diagnosis requires a detailed structural history, And even if you encounter a patient with a primary headache disorder, they can have secondary headaches or they can develop secondary headaches. So always consider both when you encounter them and watch out for these red flags, the 10 criteria to go back and then to really investigate further if needed to you can and then you can potentially diagnose and prevent the dangerous outcomes. So these are my references, and let me know if you have any questions. Thank you.